Welcome to the Deep Dive. Today, we're looking at a really foundational piece of law, the National Health Act 61 of 2003. It actually came into force back in July 2004.
That's right. And it's foundational because, well, it's essentially the blueprint for South Africa's entire health system.
Yeah.
It tries to create a single, unified structure.
A unified structure.
Exactly. One that takes the promises made in the Constitution about health and turns them into concrete duties for government at all levels, national, provincial, and importantly, local too.
Okay, so our mission today is to sort of break this down, make it clear. We want to cover its main goals, how it's structured, and critically, the rights and duties it sets out for, well, for everyone, patients and providers alike.
Makes sense.
So maybe let's start right at the top.
Yeah.
What's the legal bedrock here? What constitutional mandates really drive this act?
Good place to start. The Act itself, right in the preamble, points to the Constitution. It leans heavily on, I think, four key constitutional rights. First, there's the progressive realization of the right to access healthcare services. That's Section 27(2) of the Constitution.
Hold on, progressive realization. That sounds like legal jargon. What does that actually mean for someone listening? How does that work in practice?
Yeah, good question. It basically means the government has an ongoing duty to improve access to healthcare over time using the resources it has available. It's not something you achieve overnight. It's a continuous effort.
Right, so it's an improvement goal, not an instant fix. What are the other three?
The other three are more immediate guarantees. Section 27(3) says you absolutely cannot refuse anyone emergency medical treatment. That's a big one.
Definitely.
Then Section 28(1)(c) guarantees every child the right to basic health care services. And finally, Section 24(a), the right to an environment that isn't harmful to your health or well-being.
Got it. So those four pillars: improve access continuously, never refuse emergencies, basic care for kids, and a safe environment. That's the foundation. So how does the Act in Section 2 translate those pillars into its own objectives? What's its stated mission?
Well, the core mission is to establish this national health system we talked about. And importantly, it explicitly says this system includes both public and private providers.
Okay, so it's not just about the state sector.
No, it encompasses everything. And the goal for this system is to provide the best possible health services equitably, again, always within the constraint of available resources.
Yes.
And building on that equity point,
Yes.
the Act specifically calls out the need to protect the rights of vulnerable groups.
Yeah.
Women, children, older persons, people with disabilities. They need specific focus.
That makes sense. Now let's get practical. Money and access. Section 4 talks about this. How does it work? Who gets free services in, say, a government clinic?
Okay, this is crucial. The law says state-funded clinics and community health centers must provide free primary health care services to everyone. Well, almost. There's a key exception. This general free service doesn't apply if you're a member of a medical aid scheme or if you're getting compensation for an occupational disease, like from the compensation fund.
Ah, okay. So if you have private cover, the expectation is you use that for primary care? Is that the idea? To save state resources?
That seems to be the logic, yes. Rationing scarce public funds. But, and this is really important, even if you do have medical aid, some services must still be provided free at public facilities.
Oh, which ones?
The Act mandates free services for all pregnant and lactating women and for children under the age of 6, regardless of their medical aid status.
Right.
Also, termination of pregnancy services must be provided free. And of course, that non-refusal of emergency treatment we mentioned earlier implicitly means emergency care is free at the point of service initially.
Okay, that clarifies the access rules significantly. So we have the constitutional basis and the access rules. Let's dig into Chapter 2 of the Act, which deals with the rights of users. This feels like the heart of the patient experience. And you mentioned emergency treatment already.
Yes, Section 5 is crystal clear. A healthcare provider, or a whole hospital for that matter, cannot refuse a person emergency medical treatment, period.
Non-negotiable. What about day-to-day interactions? Information and consent seems central here.
Absolutely central. Sections 6 and 7 focus on the idea of the informed user. You, as the patient, have the right to full information.
Full information meaning what exactly?
Means your health status, what's wrong, essentially.
Yeah.
Your treatment options, all of them, the benefits and risks of each option, the likely costs involved, and, very importantly, your right to refuse any or all treatment.
And it's not just about dumping information on someone, is it? I remember reading it has to be understandable.
It's exactly right. Section 6 insists the information must be given in language the user understands, and, crucially, in a way that respects their level of literacy. You can't just hand someone a complex medical journal article.
Right. It has to be genuinely comprehensible for consent to be meaningful.
Precisely. That's what informed consent requires. It must be given by someone with the legal capacity to do so after they've received and understood all that information from Section 6.
What happens if someone can't give consent? If they're unconscious, for example?
The Act sets out a very specific hierarchy. If the user can't consent, you first look for someone they previously mandated in writing. If not, then you go to a spouse or partner, then a parent, then a grandparent, then an adult child, then a sibling.
Wow, that's detailed.
It is. It's listed in that exact order to avoid confusion in urgent situations.
Are there any situations where a doctor can treat without getting consent through that whole chain?
Yes, there are limited exceptions. Primarily, if there's a serious threat to public health, controlling a dangerous infectious disease outbreak, treatment might be mandated.
Okay.
And second, if delaying treatment to get consent would likely lead to the person's death or cause irreversible damage. Treatment can't proceed then unless, and this is key, the person had previously clearly refused that specific type of treatment.
That makes sense. Protect life, but respect prior refusal if known. What about privacy? Confidentiality of records, sections 14 and 17 cover this.
Hugely important. Section 14 states that all information concerning a user, including information about their health status, treatment, or stay in a facility, is confidential.
And getting access requires
explicit written consent from the user or a court order, or if there's a specific law requiring disclosure, or again, if non-disclosure poses a serious threat to public health.
And there are teeth to this. What if someone breaches confidentiality or messes with records?
Oh, yes. Section 17 lays out penalties. Falsifying records, allowing unauthorized access, even improperly destroying records. These are offenses. You could face a fine or even imprisonment for up to 1 year.
Okay, so the system protects user information quite strongly. But it's not all about user rights, is it? Section 19 mentions user duties.
Correct. It's a two-way street. Users also have responsibilities. They need to adhere to the rules of the health establishment, visiting hours, things like that.
Right.
They need to provide accurate information about their health to the best of their ability. They have to cooperate reasonably with healthcare providers.
Makes sense.
And treat the staff with dignity and respect. Also, importantly, if a user decides to refuse treatment that's been recommended, they're generally required to find a discharge certificate, basically acknowledging they're going against medical advice.
That protects the provider too, I suppose. And Section 18 covers complaints.
Yes, it mandates that every health establishment must have a clear complaints procedure. It needs to be displayed visibly, and if a complaint falls outside their scope, they need to help refer it to the right place, like the OHSC or a professional counsel.
Okay, so we've got the rights and duties sorted at the user level, but running this whole system needs structure. Let's talk about governance. The Act mentions cooperative governance. What does that look like in practice?
It means that responsibility for health isn't just dumped on the national department. It's shared across national, provincial, and local government. Right. The Act creates structures to make sure they, ideally, work together.
Like what kind of structures?
Well, at the top, you have the National Health Council, the NHC. Its job is to advise the Minister of Health on broad policy, national health goals, norms, and standards, things like integrated planning across the country. The Director General of Health handles the day-to-day implementation, international liaison, disaster coordination, etc.
So the NHC is the big picture advisory body. What about the provinces?
Each province has a provincial health council, or PHC. They advise the provincial MEC for health on issues specific to that province, things like planning for specialized hospital services or coordinating human resources within the province.
Okay, national advice, provincial advice. Where does the actual frontline service delivery get coordinated?
That's meant to happen through the district health system, covered in Chapter 5. The idea is to align health districts with municipal boundaries.
Linking health services directly to local government areas.
Exactly. And each district is supposed to have a district health council. Their role is crucial. Planning, budgeting, and monitoring all health services, public and private, within that district, aiming to serve the needs of the local population.
So that's where the municipality comes in. Section 32 lists specific municipal health services. Why are things like water quality and waste management under a health act?
Because of that constitutional right to a healthy environment we mentioned earlier. Health isn't just about clinics and hospitals. It's also about prevention and the environment people live in.
Right, the social determinants of health.
Precisely. So municipalities are legally responsible for ensuring services like water quality monitoring are effective, food control happens, waste is managed properly, premises are inspected for health risks.
What else?
Also, surveillance and prevention of communicable diseases, except for immunizations, which usually sit at a higher level, vector control, like spraying for mosquitoes, environmental pollution control, dealing with the disposal of the dead, chemical safety. It's the public health groundwork.
That's quite a broad mandate for local government, and I know there are changes coming potentially with the National Health Insurance Act amendments.
Yes, so the uncommenced sections of the NHI Act propose establishing district health management offices, or DHMOs. These seem intended to take over and perhaps strengthen that district-level coordination role, especially for primary health care. It signals an ongoing effort to refine that local management piece.
Okay, moving to our final section. How does the Act ensure quality and enforce the rules? This involves some really significant regulatory powers. Let's start with the Certificate of Need from Chapter 6, Section 36. This sounds like a major control mechanism, maybe especially for the private sector.
It absolutely is. It's a cornerstone of regulation for all health establishments, public and private, and even health agencies. You need to apply for and get a certificate of need from the Director General before you can establish, build, or even significantly modify a health facility.
Even for adding beds or buying certain equipment.
Yes, or acquiring prescribed high-end technology. It's broad. And it's not just a tick-box exercise.
Why not? What makes it such a potentially powerful tool? What does the DG have to weigh up?
The DG must consider several factors aimed squarely at promoting equity. They have to look at the need for equitable distribution of health services across the country. They need to consider the population's specific health needs, the demographics and epidemiology, the disease patterns.
So they can't just approve a new private hospital anywhere it wants to set up.
Not easily. They also have to consider the need for an appropriate mix of public and private services in that area and the financial sustainability of the proposed project. The goal is to use this certificate to actively steer resources, both public and private, towards areas of greatest need, preventing overconcentration in wealthy areas.
And if you operate without one?
Serious consequences. The penalty can be a fine or imprisonment for up to 5 years. It shows how seriously the state views this regulatory power.
Wow. Okay, so that's steering development. What about ongoing standards? Chapter 10 sets up the Office of Health Standards Compliance, the OHSC. Is this the enforcement arm?
That's a good way to put it. The OHSC is the watchdog. Its main job is protecting users by monitoring whether health establishments are meeting the prescribed norms and standards for healthcare.
How do they do that?
They have inspectors who go out and assess facilities again, both public and private. Based on these inspections, they issue certificates of compliance. These certificates are only valid for a maximum of 4 years, so facilities need ongoing checks.
And they handle complaints, too.
Yes, if a complaint relates specifically to a breach of norms and standards, the OHSC investigates. They have the power to take action against non-compliant facilities.
And within the OHSC, there's the Ombud, Section 81A. What's their role?
The Ombud is an independent figure appointed by the minister for a single, non-renewable 7-year term. Their specific job is to investigate complaints from the public about norms and standards violations, impartially and independently. They then report their findings and recommendations back to the CEO of the OHSC. That is another layer of accountability.
Okay. Lastly, let's quickly touch on Chapter 8, Control of Human Tissue, Gametes, Blood. This sounds sensitive.
Highly sensitive and governed by strict ethical rules. Section 57, for example, explicitly prohibits the reproductive cloning of human beings. Creating a genetic copy of a person is banned.
What about therapeutic cloning?
That's potentially permissible under strict conditions, usually for research aimed at treating disease, but reproductive cloning is an absolute no. Another major point is payment, Section 60.
You can't sell your body parts, basically.
Essentially, yes. The Act prohibits giving or receiving any financial payment or other reward for the donation of human tissue, gametes, sperm or eggs, blood, or blood products.
But what about costs? Like travel to donate?
Reasonable costs directly incurred by the donor can be reimbursed, but selling or trading these materials is a criminal offense.
And there are rules about transplants, too, particularly for non-South Africans.
Yes, Section 61 puts a limit there. An organ removed from a South African citizen or permanent resident cannot be transplanted into someone who isn't a citizen or permanent resident unless the Minister of Health gives specific written authorization. It's about prioritizing the national organ pool for locals first.
Right. So pulling all these threads together, it seems like the Act operates on maybe three main levels. First, securing those fundamental constitutional rights for every person interacting with the system.
Yes, the rights to access emergency care, consent, confidentiality.
Second, building the scaffolding, the cooperative governance structure across national, provincial, and district levels to actually deliver those services.
The NHC, PHCs, the district health system, the municipal role.
Yeah.
And third, layering on these quite powerful control mechanisms, the Certificate of Need, the OHSC inspections, the Ombud, and those strict ethical rules for things like tissues and organs to ensure quality and steer the system towards equity.
That's a good summary. It's a complex machine designed to translate high ideals into practice.
So the final thought for you, the listener. What does all this intricate detail really mean?
Well, the National Health Act is clearly this massive, ambitious attempt to make good on the Constitution's promise of health access for all. But perhaps the core tension to think about is this. You have these very detailed top-down regulations, things like the Certificate of Need trying to dictate where private facilities can open, or strict rules on organ use. How effective can those kinds of controls really be in driving equitable access and actually realizing health rights progressively across a country with such vast inequalities and resource limitations as South Africa?
The Act provides a vital legal framework, no doubt. It sets the goals and the rules. But making it work effectively on the ground, ensuring those regulations truly lead to fairer outcomes for everyone, well, that's the ongoing challenge. That's the story still being written.